Hey guys, it's me, Dr. Katz. I wanted to talk to you about polycystic ovarian syndrome. So first of all, what the heck is it? Who gets it? Who's susceptible? What are the signs? What are the symptoms? What is it caused by? How can we treat it? What are the prospects for fertility? We're going to go over all of this. So buckle up. Here we go. So polycystic ovarian syndrome is a syndrome in which three main things happen. Okay. Number one, the woman has elevated levels of male hormones, otherwise known as androgens, in her blood, right? Number two, her menses are all over the place, very irregular because of a lack of ovulation. And then number three, she has multiple cis fluid filled sacs in her ovaries, as opposed to like one dominant follicle like she's supposed to. Okay? So those are your three main features. It's not like there are not a ton of other signs and symptoms, but those are the ones that I wanted to start with. So let's break things down. So what causes PCOS? Well, we don't know for sure. But I can tell you that I personally believe, and we have some data to support this, that there's got to be a genetic component. And by that I mean that PCOS does tend to run in families. And it tends to run in the families that possess the insulin resistance gene. So that's right, ladies, that's what I'm saying. If you have been diagnosed with PCOS, you likely had this gene for insulin resistance passed down from some beloved relative. Thank you very much. So polycystic ovarian syndrome, it affects as many as 7 in every 100 women. So that's like 7%. That's huge. That's significant. That has an impact medically and on fertility and further down the road for diabetes costs, metabolic syndrome costs. There are far-reaching implications of this syndrome. So polycystic ovarian syndrome is not really its own thing. It's part of a whole group of signs and symptoms that really come from the root cause of insulin resistance. So let's talk about that first. So insulin resistance, okay, occurs in a person after being genetically susceptible when your body tissues are resistant. In other words, they fend off the effects of your body's own insulin that is made by your pancreas. So let's talk about the difference between a normal metabolism and a metabolism in a person who suffers from insulin resistance. Okay, so let's break this down. So in a normal metabolism, we take in food, hopefully perfect for our body type, haha, and our pancreas sees the food, and it makes just the right amount of insulin to break down the food, okay, and then send just the right amount of glucose into our muscles so we can go along and get energy and fuel and head around our day, okay? In a person who's insulin resistant, we got multiple problems. First thing, we're normally not eating right for our body type, and or we're skipping meals, which sends our body into a storage mode, right? So when we eat, usually wrong for our body type, our pancreas freaks out and makes way too much insulin, more so than what we would normally need to break down that same amount of food, right? And then to top that off, our own body tissues are resistant to that insulin, okay? So we've made too much in the first place, and your body tissues are like, nah, I don't feel like you're doing your job right now. So we eat, and the food sits right in our bellies, okay, along with all that insulin, right? So we don't get any energy. Matter of fact, we might get sleepy after we eat, okay, and can barely drag ourselves through the rest of the day. Meanwhile, all that food and insulin just sits there in our abdominal fat. And then since insulin's a hormone, it gets bored. And it wants to do something, right? As all hormones do, right? So it calls in its friends fat and salt and water, which is why you get that incredible bloat with insulin resistance. You can blow up to like pregnant size in a day, then deflate the next morning, and the whole vicious process goes on and on over again, right? Each and every day. You start off the day kind of flat-bellied, and then you get all bloated up by the end of the day, and then we repeat again. Ugh. So what else does insulin do? Well, this is where the PCOS kind of comes in, and where metabolic syndrome comes in. So that insulin, okay, now it's called in its friends, fat and salt and water, and bloated you up, right? Well, now it's looking for an organ to work on. So it goes for the ovaries. Now, in a person who's insulin resistant, when that insulin begins working on the ovaries, it causes the ovaries to generate multiple little cystic structures. Almost like if your doctor's ever told you about a string of pearls look on your ultrasound, that's when there's these little black dots all around the outside of the ovary instead of one central large dot, meaning that that ovary is not ovulating regularly. It has a bunch of immature follicles because of the effects of insulin. And then take that a step further, and that insulin and all those extra follicles then start churning out extra male hormone. Because believe it or not, our ovaries make progesterone and estrogen, which is what we always think of, and testosterone. And wouldn't you know it, it's our boy hormone levels that, when normal, make us feel robust, make us want to have sex, make us have good energy, have good muscle tone. But when they're too much, they get broken down into these byproducts, which then goes to your skin and makes you have acne and pimples and excess hair growth, and then goes to your scalp and makes your hair literally thin out, makes your scalp really shiny. And the insulin plugs all the little hair follicles so that when we shed our normal 30 hairs a day, we don't get them back, because then the insulin and that testosterone moves in and plugs those follicles. So that's how insulin resistance plays into polycystic ovaries. So let's go back to some of the symptoms of polycystic ovaries. So here's some of the things that I commonly see. I commonly see a skin condition called acanthosis nigricans, which is kind of like a velvety, kind of a brown skin. A lot of the time you'll find that these patients have darkened skin in their genital area or in their armpits or even around their neck, that gets worse as the insulin resistance increases. You'll also find that these patients suffer from hirsutism, that's excess hair growth. So remember how I was just talking about how once the insulin works on the ovaries, they start churning out extra testosterone. That testosterone gets converted to breakdown products that go to the skin and go to the scalp. So we lose hair here where we don't want it, but gain hair here where we don't want it either. Also getting acne, because that extra testosterone breakdown products from the insulin resistance then just bubbles up under the skin, and you get this acute bacteria infections. You get those big cystic ones that don't pop. So don't let any dermatologist tell you that hormonally influenced acne with insulin resistance is the same as regular acne. It's treated differently, but that's another discussion. That's in my hormonal acne video. Insulin resistant folks, 4 out of 5 of them are going to be obese, because like I was talking about, remember I said how the insulin and the fat and the salt and the water all get collected in the abdomen region. There's where that obesity comes from, because it doesn't go anywhere because your body's not metabolizing it effectively. Now, 1 out of 5 patients actually with polycystic ovarian disease are very, very thin, and they're in fact more difficult to treat than the obese patients, believe it or not. So it's not a guarantee that a person has to be obese in order to have insulin resistance and polycystic ovarian syndrome. Okay? Now let's look at some other things about here. So we talked a little bit about what causes PCOS, right? We don't know. We're assuming that there's a genetic component because it makes sense, because I see it in families, and it makes sense that at least the insulin resistance portion of it gets passed on from woman to woman or man to woman, either parent. So what are some of the health risks? Well, the one that a lot of patients come in to see me about is the fertility issues. Now, in order to be fertile and to have babies, you got to be able to ovulate. When you are insulin resistant and suffer from polycystic ovarian syndrome, your ovaries are not ovulating regularly. And if you're not ovulating regularly, that egg is not getting released, and there's nothing to meet up with the sperm that happens during the intercourse to actually start making the baby in the first place. So that is one of the biggest challenges with PCOS, is fertility. But this is treatable, okay? Second thing, high blood pressure. This seems to be a secondary effect of insulin resistance, which then leads to metabolic syndrome, which I alluded to earlier. Metabolic syndrome, okay, consists of elevated blood pressure, elevated triglycerides, obesity, insulin resistance, and even diabetes, okay? Also, too, in these patients, your waist measurement tends to be greater than 35 inches. And also, too, you have lower than normal levels of good cholesterol, but elevated levels of triglycerides and bad cholesterol. Okay, so let's summarize that again. Got elevated blood pressure. You've got that waist measurement greater than 35 inches. We've got the higher than normal blood glucose and the diabetes risk like I was talking about. We've got the elevated triglycerides and the low good cholesterol. Okay, so these are more health risks of insulin resistance and polycystic ovarian syndrome, right? Other health risks longer down the line after it goes untreated are even endometrial hyperplasia, because usually these patients that have suffered from long-term anovulation and not having regular periods have allowed their endometrial lining in their uterus to grow and grow and grow unchecked because it's not getting shed regularly, and therefore that extra estrogen effect leads to abnormal cells, precancerous cells, and eventually even a risk of endometrial cancer. So it is very important when these patients with irregular periods or no periods that they get to a physician to make sure that that's not happening. Let's see what else we've got to tell you about. So I want to talk to you about how do we diagnose it, right? So here's how I diagnose it. So when a patient comes in and she has some of the complaints, she's got the coloring around her skin, she's got the hair, she's got the acne, her periods are irregular or non-existent, she's got that abdominal obesity, got a family history of diabetes perhaps, I start with a detailed clinical history and physical exam, right? That is your first step in everything. You've got to listen to what the patient's telling you, you've got to write everything down, you've got to note it in their chart, and you've got to put it all together like a giant puzzle, right? So first part, history. Second part, do a physical exam. Look for that acanthosis. Look for the darkening of the skin. Look for the abdominal obesity. Do a pelvic exam. Palpate for cysts. Get an ultrasound. Look at the appearance of the ovaries and see if they have that string of pearl appearance that I mentioned before. And also, get some lab work. Let's look at that male hormone levels. Let's do a hormone panel. Let's look at her estrogen and progesterone as well. Let's check her glucose. Okay, let's check her fasting insulin. Let's check her cholesterol. Let's put it all together. That's how we diagnose this disease. So then it's a matter of then, well, how do we treat it then? Is it all just lost? Are you going to get diabetes eventually? Are you going to never have babies? Is it all over? Well, no. I suffered from PCOS myself, and I have beautiful children, and I'm very, very grateful. So no, this isn't the end. This isn't something that's untreatable. This isn't something that's unmanageable. We can manage each part of it. I'm not saying it's necessarily easy, but the biggest thing, first and foremost, is to try and manage the insulin resistance component with eating better, not skipping meals, focusing on lower carbohydrates, not keto, but just balanced and lower carbohydrates. Adding insulin sensitizing medications such as metformin, helping the woman to start ovulating again, which will then restore her periods. We help her with ovulating also with the metformin, because as we treat the insulin resistance, then the ovaries begin to be able to start functioning again. If the goal is not so much ovulating for fertility, but just regulating periods, we can do that with birth control. That's not making the woman ovulate, but it's mimicking the same hormonal signals so that the uterus at least knows to shed regularly so that that lining does not build up. We treat the blood pressure. We try to help the patient lose weight, again, with focused dietary tips, perhaps some metformin, methods and measures to increase their insulin sensitivity, and also advising exercise. See, this is one of those few conditions where exercise is more than just a cliche. When you actually physically move, and I'm talking 30, 40 minutes, 3 times a week to the point that you're sweating and your heart rate is increased, you can actually take that insulin that's sitting in the abdominal fat and shove it into the muscle where it belongs so it can actually do some good for you. So you can literally change your body chemistry just with exercise with this very significant condition. So that's a little summary for you about insulin resistance and polycystic ovary syndrome. If you've got other questions, give me a call. Message me through our Facebook. Call us at the office, 734-242-5588. If you think you have this condition, come on in and let's get you taken care of. Have a great day.